All right, I will go ahead and get started here with some introductions. Welcome everybody. I'm Melanie Escher with the Arizona Telemedicine Program and Southwest Telehealth Resource Center, and welcome to today's program. Quickly with the university, we respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners regions with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So as you join today, of course, your phone or your computer microphone were muted. Time will be reserved for Q&A. Please use the chat function. We like to use that, and we'll be monitoring the chats if any questions come in while our presenters are presenting. There is CME credit for this, and we do have the phone call-in cord number, which is in the evaluation, and everybody else is also able to get certificates for attending today. We have a lot of EMS folks. Thank you again for joining us. Let me go to the next slide here. So this was sent out in the last email for all of those registered. I won't go through it, but here's the outcome objectives, our crediting statement, and the disclosure statement. Of course, we have our standard disclaimer. I'm not going to read it out loud this time. You can see that there. And be sure to check our website for upcoming webinars. We were just discussing some of our next topics for this series, and Dr. Klotz can mention a little bit more about that. And again, your opinion is valuable to us. So some of the responses that we've been getting are going to be utilized as topics for upcoming talks. So please do that evaluation. Give us your ideas and the thoughts of what else you'd like to hear about relative to this series. And I'm going to go ahead and start with the introduction of Dr. Klotz and his crew. He will be introducing who's going to be speaking and what they're going to be talking about today. Dr. Klotz is also the medical director of the Arizona Telemedicine Program. So without any further ado, Dr. Klotz, I'll pass the mic to you.
All right. Thank you, Melanie. Well, good afternoon, everyone. Thanks for joining us for a very, what promises to be an interesting discussion on psychedelics. And they're all homegrown here in Arizona. I'm not going to make a lengthy presentation of who the speakers are because we've had them before, and they both are very excited about today's topic. And so I'm going to have to even cut down their slides if that's even possible. I don't know, since I'm more a host in name than in reality. But at any rate, Dr. York will begin talking first about Datura and peyote, and he is a pharmacist without peer and a pharmacologist as well. Our second speaker will be Dr. Shirazi, whom you have heard speak before. He is not only an emergency room physician, pharmacologist, but he's also the director of the Arizona Poison and Drug Information Center. So Larry, one other thing I wanted to mention. Melanie had said that you had written in topics to be presented, and indeed we will get around to doing all of these, including someone had written last time about doing Gila monster bites. We not infrequently see these, and we'll be presenting that soon. So I'll just turn it over to Larry, and then hopefully we'll have some time reserved for questions, but we'll see. Larry?
All right, we're getting this ready. That was quite the introduction. I look forward to letting you all down after that. All right, let's see what we've got here. All right, so we're short on time. Like Dr. Klotz mentioned, we got some really exciting stuff for you today. So right off the bat, I'm going to talk about Datura, which I would wager of the things we're talking about today might be the one that folks are the least familiar with. But let's set it up with a case. Quite a lot of things we can choose from in terms of exposures to this one. But I thought an interesting one here would be to look at a real case of a family of 6 who all were admitted to the hospital after consuming herbal tea. So what had happened? Having a family get together, some of this tea was consumed after purchase from a local herbist, and the recommendation was this is a refreshing product. It's going to be great. Don't worry about a thing. Give it a try. And within about the next 30, 60 minutes, these folks were already starting to have hallucinations, getting agitated. And we'll talk a bit more about it here. Some of the family members did have backgrounds in the realm of depression. One in particular had bipolar disorder that was being treated. But many of these family members, none of this made any sense. So these individuals consumed this. It was later discovered that the herbs were essentially coming from a Datura species, of which there's numerous. We'll talk quickly about a couple of them. But let's look at the specifics. We've got a 67-year-old male. This fellow required restraints upon being brought into the hospital. 32-year-old female, pupils dilated, dry mucous membranes. And for the sake of time, I'll skip through here. You're going to see a lot of recurring things, particularly in the realm of anticholinergic symptoms. And a lot of these folks tended to be pretty copy paste in terms of their symptoms. Varying severity, we had one individual that actually got better much faster, as we'll find out. But we did have a fairly young individual here, the 15-year-old male. And as we'll see near the end, this particular one tended to have a bit of a rougher go of this than most. But let's look at this plant itself. Now, Datura is the official name of this family, this species, but you may know it as Jimson weed. Thorn apple is another name it's called. I think I saw Hell's Bells mentioned once. I think that's my favorite one for this thing. And to be fair, the name fits this plant. It is a particularly unusual looking one. And if you look here at the top right, the fruit, I can't think of another fruit that looks as unappetizing and stay away from me as this one. So I can't say that this plant doesn't give you a number of chances to get away from it. With that said, it has been used for thousands of years. I think the farthest back I was seeing is some evidence at least 3,000 years ago that folks were using this plant for some purpose. Now, there's a number of purposes. We'll talk more about the poisoning part of it. But as is with many of these herbs that come from folklore, a number of uses have been attempted with it. Now, there even in here is a translated saying. It's a Tohono O'odham song that they would sing, maybe when going off to do something for folks that may have been sick. But the translation, I ate the thornapple leaves, and the leaves made me dizzy. I drank thornapple flowers, and the drink made me stagger. Not the greatest start to talking about this one, but all of this aside, I wish we had a bit more time. Fascinating history with Datura. It has been used as a poison, used in suicides, and there are plenty of cases even nowadays where it's inadvertently getting mixed into even everyday household foodstuffs, and tons of people end up inadvertently getting sick from this stuff. Now, looking at Datura, it is in the Solanaceae family. You may all know it is nightshade. And that tends to be the term that I think triggers a lot of folks like, oh, I think I have heard of this one. And to be fair, very much the same sort of stuff you would see in terms of consuming nightshade to this specific species there. Now, if you're a botanist, I am sorry, I am not going to get into this debate. There are tons of different Datura species. They are, for the most part, pretty different from one another. But in the Sonoran Desert, we are mostly talking about a few different ones. The two I put on here of note is Datura discolored, Datura wrightii, and they all have different names in terms of thornapple, sacred apple, a lot of different common names that you might hear. But primarily this is coming from Mexico. That seems to be where this got started. And at this point, there's even places on the Eastern Hemisphere that have Datura species all of their own that they think may have been brought over there. Now, where does this thing actually appear? This, I think, lends to why you might have to consider this, especially as we'll find out for more adolescent patients. Depending on your region, this is not a terribly hard to find plant. In some places in the world, it's a roadside weed. You can walk out. In some of these cases of incidental poisonings, it was growing around everyday crops that people were harvesting and inadvertently got mixed in. Now, the one benefit here, way back when I talked about Sonoran desert toad, we tended to worry about animal exposure. But in this case, this tends to be ignored by most animals. As I mentioned before, the plant could not look less appetizing to most folks, quite a pungent smell. Now, what are we talking about? You may have been able to guess, especially once you heard nightshade, but we are looking at a lot of anticholinergic effects from drugs like scopolamine, atropine, hyoscyamine. So, quickly looking at the mechanism of action here, we're seeing effects on muscarinic receptors, and that's what very quickly can bring us to having these anticholinergic effects. And yes, while death is not typical, it is in play when we talk about Datura species. Plenty of documented cases of this happening. Now, I think probably most folks here, especially folks that are coming here from medical school, hopefully remember this old adage of anticholinergic syndrome: red as a beet, dry as a bone, blind as a bat, mad as a hatter, hot as a hare, full as a flask. I hope you will forgive me for not finding a great picture for full as a flask. I will admit I found that one challenging and maybe inappropriate. So I hope you're happy with the rest of these. But these are the things that we're looking for. And I do want to point out that depending on the exposure, these can look particularly concerning. The mydriasis may be one-sided. It may really freak people out that there is a concerning cerebral issue that may be in play with some of these folks. Now, looking at management, gastric decontamination is typically recommended. Things to consider here, because we're talking about anticholinergics, there may still be benefit to doing this even hours later. We're going to see delayed gastric motility, emptying. You still may be able to get some of this poison that's sitting in there. Now, as far as everything else we're talking about, we're typically going to look to our standard measures. Hyperthermia can be in play. Conventional cooling measures typically do the trick. Sedation with benzos, and by a lot of the case reports that are published, typically is something that probably will be considered for many individuals. Now, depending on the reference you may be looking at, they do urge caution in doing this with children just to make sure that all other causes have been fully considered. Now, things also here, I don't have it on the slide, but of course, you want to be worried about using another antihistamine or something that may have some of these anticholinergic effects on top of what this potential exposure could have been. Now, this I think could be something that you might run into if the main presentation, other than the mental state, could be flushing. Something we may worry about is some sort of reaction, and by giving an antihistamine, we may inadvertently make things worse. Now, I do want to talk briefly about more severe case management for these individuals. Now, physostigmine's the antidote of choice. Typically not recommended is neostigmine due to penetration through blood-brain barrier and effects there. Either way, even when physostigmine is used, the thing I want you all to remember is that it does have a short half-life. So even if you do get temporary benefit, you may need to consider re-administering later, or the symptoms could very well recur. And of course, with physostigmine, I think the thing to take away from this drug is be careful when you're doing it. Physostigmine is a pretty good antidote for this, but you may very easily push this individual into essentially the complete opposite set of symptoms. So we could worry more about bradycardia of a concerning level. So do be aware that just because we've got that antidote, you may still need to be very careful with what you're doing there, and why it may tend to be reserved for these more severely ill folks. And when we talk severely ill, we're looking at folks presenting beyond the norm, which does not apply, thankfully, to the folks in our initial case: arrhythmia, severe hypertension, convulsions, coma, certainly anything that is of a particularly concerning state of what may happen to them, as people do die from these exposures. Now, let's look quickly at the conclusion for our poor family here. Thankfully, everything tended to work out okay. We had a 67-year-old male, fluids for hydration, and this was in Iran, I believe, that they were done. So you might see some slight differences, but midazolam, full recovery after 2 days. And if you skip forward here, you're going to notice a lot of the same stuff here. Benzos were pulled, hydration was pulled. In most cases, folks got better after about 1 to 2 days. We got a 50-year-old male here who recovered not even half a day later. This guy was A-OK to go. But in this particular setting, the 15-year-old did seem to have the worst experience with this. Kids do seem to be more susceptible to drugs like atropine. And this kid did have a 2-day stay in the ICU, got better, but with essentially in this case, per this hospital's protocol, the midazolam dose was essentially maxed out. I mean, high level of sedation here. But once they improved, after one more day of observation, everything tended to be okay here. Now, before we briefly touch on the conclusion, like with any of these things that we talk about, I do want to mention, could folks with a psychiatric background be at higher risk of having more severe symptoms or maybe longer lasting symptoms? And it does appear that that is a possibility. So as we mentioned here, a couple of these patients did have issues with either depression, bipolar disorder. And thankfully, in this case, they made a recovery, but you could see cases where you don't quite see a full recovery after this 48-hour period. It could be 1 to 2 weeks where some of these symptoms may linger for some of these folks. And there is always the rare case where psychological issues follow the individual. And depending on the severity of illness, even end organ damage that could potentially happen depending on what's going on. But in conclusion, I think the thing to take away is a higher degree of misuse in adolescence. I think the silver lining is, yes, this may be an easy thing to get for a quick high, but this is typically a high that you don't forget. More people cite this as saying, yeah, that was not a fun ride. Think my Datura days are behind me. It can appear deeply concerning on presentation due to the odd manifestation of some of these symptoms, but thankfully, with supportive management, it does tend to resolve fairly quickly. And while there is a low rate of death, this is here more as a reminder that death is in play, so do be wary depending on the presentation for your particular patient. All
Larry,
right.
before you go
Yes,
on, let
jump
me
in.
add a couple of things on this because we see this on a regular basis, especially with Sacred Datura here. One thing that we see, it's along with it in the summers, we see also heat exposure. Especially in teenagers, they smoke it or they make a tea, and then in the summer, you see them hallucinating and walking in the desert, and they have heat exposure. The other thing is we use the physostigmine as a drip on a regular basis in the ICU so that people are not pulling out their own IV lines or, falling over, because otherwise you're going to be needing a sitter. They always do it in conjunction with toxicology consult, and we see about, I would say, about 10 cases of severe anticholinergic. And then the interesting thing about Sacred Datura or Jimson weed is, of course, it was one of the first uses of chemical weapon during the Civil War, or actually Revolutionary War. Jamestown weed was when the residents provided the redcoats with a porridge containing Jimson weed. And there's a very nice description of what happened to the redcoats.
That was an ominous spot to end on. Let me ask you, since we've got you, in terms of fatalities that you're seeing yearly, where would you put that number?
Well, I would tell you that we do not see, even with the tea, really bad anticholinergic toxicity that would lead to dysrhythmias. And that we see it in conjunction with that over-the-counter Benadryl. And with that, we get much more toxicity in terms of sodium channel toxicity and dysrhythmias. And unfortunately, I have seen deaths from that anticholinergic toxicity. So it is a potential with high enough concentration of a T that can happen. But I have not personally seen it. But I have seen actually families who were exposed thinking that the early stage of Datura is a spinach, and they serve the family. And usually it becomes child protective services type of, especially if children are involved, and they call us to help because usually it's a accidental exposure and it wasn't people trying to get high.
Wow. All right. And if you all have any questions, please make sure you put them in the chat, and we will do our best to get there for you. All right, so jumping over here real quick. All right, let me make sure. Can you all see peyote? Yes, it looks like. All right. Switching gears to another one that I think a lot of folks have heard of is peyote. So let's set it up again with a case. We have got a 54-year-old Native American male who drank peyote juice during a healing ceremony. Now, after a few hours, visual auditory hallucinations did start to kick in. Now, of interest in this particular case is this person did not sleep for the next 2 weeks as symptoms continued to worsen. They started bringing in local children to help do other ceremonies with them. They thought that their ancestors were following them, and this declined significantly over time. So finally, this individual was encouraged to seek care at a local hospital. Now, I think it is worth mentioning, as we had talked about with Datura and some of the background, this person's past medical history was significant for post-traumatic stress disorder, alcohol use disorder. And I think just to keep it on a more realistic front for a lot of our folks that are here that may work in the ED, of course, the tox screen had no other apparent positives for what's typically being done. Now, when psych was consulted, they did advocate withholding treatment. And I am curious what you all think they did for this poor fellow to help him through this. They did do something, and he was right as rain after. All right, now talking about peyote of interest, this comes from cactus, peyote cacti. Now, there's quite a number of Lophophora species that are out there, but we're looking at Lophophoria williamsii is really our big one. And if you can see the picture here, it shows up a bit dark on this monitor. It is fairly small, and it's an unusual looking type of cactus. You may be able to see that there are these unusual ridges there, almost like you could peel it like you would maybe a fruit, honestly, and have different chunks there. Now, talking more about the background, the botany of this thing, it is fairly slow growing. It can take several years to mature. Now, cultivating it, you can do it much faster, and much faster is still on an order of magnitude of potentially years, but it can be done. Now, mentioning those buttons, we'll call them, this is typically what's cut, and then often it can be dried for consumption any number of different ways. Again, this fellow drank a concoction, juice, tea, mixed with a number of different things. And just for frame of reference, while Datura, really the legality there is probably this is a bit more accessible, peyote certainly is not. It is illegal to cultivate, plant, or harvest, but it is worth noting that there are clear exceptions for Native American use, as we'll discover. If Datura has data going back 3,000 years, peyote's got data going back 5,500 years of use in this type of setting. Now, at least here we have a bit of a clearer map. Where would we find some of these peyote cacti? Now, looking at just natural regions, if we're looking at the USA, parts of Texas tend to be where this thing can grow naturally, and there it is considered an endangered species. Depending on how you harvest these buttons, which are where we're going to get into more of the psychoactive agent, you could essentially just pull maybe 1 or 2 buttons and wipe these things out if your technique is not great. And of course, as a potential drug of abuse, something that people may be seeking out to do here. All right, we had already mentioned peyote in Native American culture. Now, a lot like some of these other folklore things that we talk about, it is viewed as helping to commune with God and past ancestors. Now, we mentioned it briefly here, but a lot of fascinating discussion on the Native American church, which peyote use is a key part of what goes down during some of these ceremonies, where folks typically come about a Saturday night around 8 p.m. and during the proceedings typically will consume peyote. All right, now ways to ingest peyote. We had talked about the buttons from these cacti. Brewed in tea, they can typically be taken as a capsule. Now, why I specifically point this out is one of the limiting issues with peyote is, as what I'm seeing in the publication suggests, it has just the most god-awful taste connected to it. And if you want to get the effects of this drug, you gotta earn it. So I saw some interesting comments about this is like going to the bar and having the hangover first. That is one of the ways peyote was summed up, is probably from the bitter taste, but there could be something else to at play. Folks get real sick to their stomach and may be nauseous until they finally start to experience those effects later on. So the capsule might be a more appealing way of exposure to what we'll talk about as the key component behind peyote. But typically in these ceremonies, brewed in tea, as this fellow did, peyote juice, and some of that is to kind of take the edge off that taste. Now, what happens to you with peyote? Hallucinations, changes in perception, and again, as Dr. Shirazi will talk about, and if you were here for our Sonoran Desert Toad, very similar to LSD, psilocybin, the effects that you might get. Now, the poisonings, similar to what we've just talked about, may lead to a sympathomimetic toxidrome. We've got some of the symptoms here. This tends, thankfully, not to be as terribly common as we're seeing, or at least as severe, I should say, for datura poisonings. And Dr. Strauss, you jump in at any point if you have seen differently. But what is happening here, I think even this slide has come up quite a few times, as many of our Sonoran desert plants can cause these effects. But what we're seeing are effects on the serotonin receptors. Here specifically, 5-HT2C is what we're talking about. Now, peyote, a number of compounds that you're going to see in there. And again, of interest, if we had more time, there's some interesting stuff that we can break down in here. But the big one that we're looking at is mescaline. This is the big one that's in peyote. The key hallucinogen behind these effects, it is a full agonist for 5-HT2Z. Does have some affinity for 2A, 2B. There's maybe a little bit of dopaminergic activity, but probably pretty mild, especially compared to some of these other hallucinogenics that we're going to talk about. Now, just relating back to that case, a large portion of the drug is excreted through the urine. And I did do a quick check prior to coming here. I know we had gotten some questions. And again, if you know better, Dr. Shirazi, jump in. But I think locally, LabCorp does offer this test, a urine mescaline screening test, if you are looking to try to get an ID on this potentially. All right, now looking at some of the details, this is where you're going to start to see a deviation and mescaline starts to stand on its own. The half-life of this is around 6 hours. Now, using some of, again, and if you weren't here, you should go back and look at some of our older presentations. But previously, we had talked about a DMT analog that has similar effects from desert toad. Very short half-life. And that is where mescaline tends to be a bit more unique. A longer half-life and a longer presentation of effects from peyote use. Now, another barrier, at least, to getting these effects is that it has poor blood-brain barrier penetration. It takes more exposure to get these effects. And as you'll see here, I do have a slide comparing this to stuff like LSD, psilocybin. This is probably your least significant in terms of pretty intense stuff happening to you. Now, the delayed onset is possible for the hallucinogenic effects. This has been reported in the literature. Typically, it occurs around 30 minutes after consumption. Again, why that bitter taste and the nausea might precede this happening. Peak is around 2 hours, and it dissipates almost completely around the 10 to 12 hour mark. And that's a pretty huge number when talking about these hallucinogenics. Now, at least some things we can talk about here. There's no apparent physical dependence. Now, that doesn't say psychological dependence may not appear. Of course, this is still a drug of abuse by some individuals. Tolerance does build up after about 3 to 4 days of continuous use. So again, higher doses may be needed, but giving a break of about half a week or so does tend to reset that tolerability. Again, questions arise about, well, what is the risk of long-term psychoses from peyote use? And to be sure, there are cases in the literature of where this has happened. The symptoms tend to be compared more to schizophrenia than anything else. But as far as long-term adverse issues go, the evidence is lacking. We have a fair amount of data from folks that are using it for these more religious purposes, but even there, comparisons to folks using it recreationally, there's divergences for sure. But I think a lot of it too is I wish we had more data to really compare some of these groups. Now, this is the promised slide looking at mescaline, LSD, psilocybin. An average dose of mescaline about 20 to 500 milligrams. A typical dose, depending on use, may be around anywhere from 3 to 6 of these so-called buttons that you would get from the cacti, which, depending on even the region that the cacti came from, who knows what the exact dose might be that you get. But looking at peyote, that would average around that maybe 500, even a little bit more mark, depending again on how many buttons were consumed. Slower onset to effects, again, due to the half-life, but longer duration of the effects. And again, that to me is where mescaline tends to really stand out, is being different from some of these other things we'll talk about for our webinar series. Now, the conclusion for this case is this may be in a case this poor guy just needed to finally get some sleep. They gave him a single dose of trazodone. Guy slept for 15 hours straight and was right as rain right after, requested to be left home. And sure enough, left right after that. Followed him temporarily, and no apparent recurrence followed this individual after discharge. Interesting discussions about trazodone, how it may work on similar receptors. Is there like a weird antidote comparison or something going on there? But again, a lot of this, unlike datura, I think maybe just waiting out some of these symptoms. But in conclusion, this is still a key part of these religious ceremonies for the Native American church. Recreational use, while I can't say I've done either of these, I would tend to think this might be a bit easier than datura, but certainly starting out with peyote may be a rough ride depending on the manner in which it is consumed. But in terms of these popular hallucinogenics that we're talking about today, this probably is the weakest one, but the longest lasting. And here, talking about treatment, likely just supportive care, it is very unlikely for mescaline to lead to more life-threatening issues. All right, Dr. Shirazi, I want to take advantage of you. Anything unique that you have seen here?
We actually have had a couple of cases. The most interesting one was use of peyote button, actually small amount, 100 milligrams was used by one of the medicinal men of a tribe, and it was used to actually enhance delivery or the labor. We had a OBGYN that called us that the medicine man came in because they were having a prolonged labor and provided a button about 100 milligram. And looking into it, there is some oxytocinergic type activity that peyote also has. And the Huichol natives, which are known for their intricate beaded designs, actually you would see peyote as part of their art, which is interesting because we see peyote button on their art and then scorpions also. And there is a depiction of peyote being used during birth for assisting birth. So that was one of the first ones that we saw. And actually, we didn't even do testing because both the child and the mother were doing well. And they informed law enforcement, but nothing came out of it. The other one that we had was an adult that had taken it for a religious ceremony, and it was a little bit more effective and lasted longer, and that's why they brought the person to the hospital. But it actually, they cultivated in areas in southern Arizona also, and we've seen it by law enforcement being grown both on private and public lands.
All right, thank you. All right, with that, I am turning it over to Dr. Shirazi for something that's going to be pretty similar here to what we've been talking about. We'll wrap up our trifecta of psychedelic drugs.
Okay, let me see. I'm going to share mine. You guys should be seeing now, we're going to be talking about psilocybin. And I also put in Jody Plato, who is one of the psychiatry residents, who actually I asked her some questions about the use of psychedelics now for therapies, for various therapies, and I have a reference in here. But let's see if this thing is not moving or what's going on. Okay, here we go. I gotta go to here. Do you guys see a change or no?
No, not on this one. It's same as what happened with your
Okay,
last
there we go. How
go.
about
There we
that?
go.
Okay.
Yes.
So and here's actually a depiction of use of mushrooms, which are thought to be psilocybin-related mushrooms, both in Algeria and in South America. There's pictographs that goes back almost 3,000 years. And then there's these arts that also go about the same time back. And you can see that humans have been interacting with mushroom, and especially the psychedelic mushroom, for a long time. Let me see. Okay. So this is a survey that was done in 2021, so pretty recent. And there were 7,000 people involved in this survey, and some 7% or 500 people had actually reported that they had used psilocybin type mushrooms within the last year. So again, there is a resurgence, and I show of interest both in general population and in medicine with regard to this. Here's the structure, and again, you put the structure there, and these are really close structurally to DMT, dimethyltryptamine, and you can see both LSD, psilocybin, and DMT have a common background of structure that one can imagine. Here, I put it so that it's a little bit easier to see how these agents are close to one another. And as you mentioned, the receptor that they bind to, it's the serotonin receptor. And again, you can see the similarity of these agents with the serotonin and why they bind, and they partially activate the serotonin receptor. Here's the psilocybin, and then psilocin is actually the active metabolite of psilocybin in our body. And that's what actually crosses the blood-brain barrier and goes into the brain and becomes active. The mushrooms also have lots of harmines with the involved with them, and they have that. It's interesting that the harmines actually block the monoamine oxidase and allow for this agent to be much more effective. So it's interesting that the mushroom has both an enzyme blocker to make the active ingredient more active, already naturally present in it. This is the same depiction as you had, but here I'm showing MDMA, which is actually a methamphetamine with extended chemical attachments, which allows it to bind the 5-HT2A, which is the serotonin receptor. And as you can see, this cartoon diptograph sort of shows the commonality of the background of psilocybin, psilocin, mescaline, and MDMA, and why they can all of them interact with this receptor in the brain and in the nervous system. Again, the active ingredient is psilocin. And here I'm showing the main receptor, 5-HT2A receptor. There are many other subtypes. This is not what you would call a full agonist. So psilocin coming from psilocybin is not a full agonist. It doesn't fully activate the serotonin receptor, but it's a partial agonist. And it has downstream effects on both the AMPA receptor and MDMA receptor. These are what you would call stimulatory receptors in the spinal cord and the brain. And it's thought that not only, as you mentioned, there is some degree of dopaminergic activity, and dopaminergic activity is usually involved with what we call addiction or positive response. especially in the ventral striatum area of the brain. And there is also some depression of activity of the cytokines, such as IL-6 and tumor necrosis factor alpha. So a little bit about its history. Psilocybin was first isolated in 1957 by Albert Hofmann, and it was then sensitized in 1958. In 1970s, sort of the Controlled Substance Act put the kibosh on any type of research or medical use of these agents. And it wasn't until 1992 where NIDA and FDA, once again, they looked at these agents. They saw that there was, both in animal studies and a couple of controlled trials, and physiologic potentials of these agents to actually be used for treatment of various psychiatric and behavioral ailments. This is showing actually the resurgence of interest in psychedelic agents, whether LSD, whether even the effect of the Torah that we were talking about, or even the psychedelic effects of marijuana and psilocybin. And as you can see, we get toward the 2000s, and you start getting lots of publications about the psychedelic effect and how they can be used for therapeutic purposes. These are so far, if you look at the literature so far, where we can find either controlled trials or somewhat controlled studies to show that psychedelics in general, in specific, psilocybin can be used for treatment of ailments. It's been used for substance use disorder, both for opiates and alcohol. It's been used for treatment of depression, and has had actually some track record that one process of treatment, and I'll show what the process of treatment is not just a single dose or agent, which most people think of. It can actually have an impact on what we define as depression for a prolonged period of time. They've been used for treatment of anxiety. There are some now evidence that shows that they are also effective in compulsive or obsessive compulsive disorder, and of course, most lately with treatment of PTSD in the general population, and especially also in the population of veterans who served in wars. Doses, again, this is micrograms per kilogram that we're looking at. The onset is pretty fast, but it seems the duration is a little bit shorter. And I have some of the clinical trials that were done, and that had actually good, I would say, results associated with them. These are actually lists of these controlled trials that you can get from the clinicaltrials.org, and it shows the effect of both psilocybin, LSD, and other agents for treatment of various ailments. So one thing that most people forget, and they think that these agents can be used by themselves in a general population without a controlled setting, is to show that almost all studies show they have one thing in common. First of all, there is a period of screening and diagnosis of the ailment, whether it's PTSD, depression, and then during that period, immediately there is psychotherapy or cognitive behavioral therapy that takes place. And there's preparatory sessions for the patient to sort of understand what to expect. and how these go hand in hand with psychotherapy. And this is not that I'm going to go home and pop a mushroom and come out the other end, all dandy and so. There are multiple sessions and treatment over weeks for these agents. And I'm here in the purple circles that I'm showing is that this is not, most of these therapies are not a single time, but they have to be done multiple times under controlled setting. And then there is follow-up with, again, conventional medications and psychotherapy to be effective. So most people think, oh, these are good. I'm going to pop a pill or I'm going to pop a mushroom and that's it. And the other end, my depression is going to be gone. And the realistic view and expectation to set for the patient that is not true. That like other therapies that we have, these actually require both assessment of the ailment, preparatory session, cognitive therapy before, then multiple sessions, followed by regular regimen of medication and psychotherapy. I'm going to stop there and go to the next slide, which is actually, here we go, questions. Any questions in the...
I don't have any questions there, but I am curious. I mean, for folks that are going through those kinds of therapies, how often was there any mention made of, are they having negative consequences, adverse issues, anything along those lines?
Well, there is, depending on which one. Again, we talk about psychedelics as if this is one agent. And as you saw, the reason I put MDMA, because MDMA is actually a methamphetamine, right? And then we have actually ketamine on one end, which is the dissociative anesthetic agent. And then we have psilocybin and LSD. And then you can look at Wayasaba or, anticholinergics type of a mixture that they use. Again, it has to be designed for an individual. They are those people who cannot, for whatever reason, cannot handle. For example, you don't want to, one of the main ones is if somebody has schizoaffective or schizophrenic, these can actually make the situation worse, right? There are people who cannot handle the hypertension and tachycardia that could be associated with these. So again, have to be done under control. And there is a rate of failure that, like any other medications, and the rate of failure can go anywhere from 5 to 30%, depending on the agent, ailment, and the individual.
Mazda?
Yeah.
I have one question, and that is, since the state of Arizona is now putting out a call for research on psilocybin, are we going to be prepared for the inappropriate use of this drug or the illegal use of this drug? Are we going to see more cases of this?
So I would suggest this. It is always, there should be funding for doing actual research and being able to see if the active ingredients of these natural products, or like in the LSD itself, whether they have true therapeutic effect. But at the same time, one thing that happens is there is a general perception in the population that one can treat their own conditions by just having access to these agents. And, that's debatable. For example, the Constitution of Mexico makes it so that citizens of Mexico should have access to any agent, including psychedelic agents, for treatment of their ailments. And we see that the laws that for a long time have been there, they are changing in Mexico, in the country of Mexico. In the US, these laws are changing state per state. And whether we like it or not, some of it has to do with amount of funding that's available through adult use marijuana. That's becoming actually source of funding for these research. I think if the research is done in a correct setting, it's good to know about the therapeutic effects of these if we can help any individual. But again, I'm worried a little bit about the perception that I can use these agents on my own to treat my own ailment. And again, I understand people's concern that also when pharmaceutical industry gets involved, stuff that could be made available cheaply to people all of a sudden gets a price that they can't afford. But making these available to a whole population, or that perception that they are safe to use at any time and anywhere, I think that's a false perception, because again, it depends on any substance that we use. It's what happens to your behavior and whether you're going to do the right thing. If you're using these in a therapeutic setting and you're under observation, and then they send you home, by either a family member or somebody, similar to when we're under effect of anesthesia after a procedure, they don't let you drive. It's one thing. It's another thing to go and pop these and then get behind the wheel or try to operate machinery or do other stuff. And that's where my worry comes from, that open perception of use.
One further question. Is the mushroom available for culture in Arizona?
Well, we know that some people grow it, okay? And we know also, that people order it on the internet. So I have seen many patients who had either used it or they have it, ordered it on the internet. Most people do not tell you that they're growing it. And I know many people working, especially with their naturopaths, they tend to use psilocybin type agents. Again, do they have effects? Yes, they do have effects. And they can affect, not regulated use. They can increase your hypertension. They can cause increased anxiety and such. If you're in AFib, they can actually worsen the situation. So like many other medications, they have appropriate use, and the appropriate use is usually under direction of your physician and a sort of a regulated, I would say, distribution of medication for conditions that they work. And I really like these medications to be dispensed by pharmacists so that they can explain to people that these are agents. These are chemicals. Most people, when they say natural chemical, they think, okay, if it's natural, it means it's all safe. Well, lots of our poisons are natural.
Larry, are there any more questions on the chat box?
So there's one question. Let me field it to you first, actually, Dr. Klotz. So we have someone asking to comment on ayahuasca. Is this one that you could perceive being its own presentation, or would you just like to knock it out right now? We got 6 minutes.
I'm not familiar with it.
I know you're not, but if you wanted to plan a presentation, that's why I asked.
We actually had a presentation and we follow it. It's common in Central America and in Peru, and we have it now. People use it for a variety of treatment, both for depression, some people for PTSD, and especially childhood trauma and such, they're using it. There are some, again, investigational uses of it. And then there are these unregulated places that you go and you use it. But at least they try to observe you. It's not like they send you home with it. Most of the mixtures are they're anticholinergic with some DMT type of agents in there. They're usually mixtures. There are various mixtures that they have, and the formulation can change actually from various cultures.
Okay. Well, Larry, maybe you've discovered a topic you might want to pursue, and along with NASDA presented in the future.
To the
We're-
person that asked the question, thank you.
Yeah. Well, we'll try and bring to the fore any questions or topics that you want to do. We have a lot more still planned, but we were just, before this webinar started, we were just discussing a few others we'll probably add in, like crayfish and stuff like that. So
For
I think that's the end here, Larry.
Yeah, for the person that asked that question, you can either let us know through the comments here or when you do the evaluation. But if you would like to see a full talk on that, let us know. All
Great,
right.
thank you very much. Yeah, we'd have just a couple of minutes left. I did put the evaluation link in the chat. Please go to the evaluation and give us your thoughts of how this talk went, and then any other future topics. Yes, we've talked about Gila monsters, we've talked about spiders, the brown recluse, black widows, giant centipedes, scorpions, crawfish, various tree frogs, more fungal things that are here in the desert. There's a lot more that these guys have on tap for us. So again, please use the evaluation, give us your comments, and if you'd like, I will be sending out an email to everybody that attended today. And if you'd like to request your certificates, you can do it that way, especially for our EMS folks. Thank you again for joining us all, and be sure to watch our website for future programs. And as soon as we get the next date set up, I will be sure to send it out to everybody. And again, thank you for joining us.